Now, we are pleased to welcome Dr. Suvarna K., Professor of Department of Anaesthesiology, Government Medical College, Manjeri, onto the stage. The session will be moderated by Dr. Abhishek, Professor of Department of Anaesthesiology, Dr. Mupin's Medical College, Wayanad, and Dr. Devika, Assistant Professor of Dr. Mupin's Medical College, Wayanad.
Hello. Hello. Good evening to all. At the outset, I'll take this opportunity to congratulate the whole ISA Midcon team for organizing such a wonderful conference. Even though the Wayanad city branch being the youngest, they could organize such a wonderful team. I am sure it is the MIMS Mupin's team, anesthesia team under the guidance of Akama madam organized this wonderful CMA. And thank you ma'am for making me a part of it also. So the topic given to me is anesthesia for interventional pulmonary procedure. Actually, when I only suggested the topic, I thought it was only minimal brushings, biopsy, lavage only. When I started reading, I found that they are doing plenty of procedures. I do not know how many I will be able to cover. At the beginning, I had nothing to disclose. So, interventional pulmonology is a rapidly evolving subspecialty of respiratory medicine in which many diagnostic and therapeutic procedures are done using flexible and rigid bronchoscope. And these procedures pose unique anesthetic challenges because both the anesthetist as well as the pulmonologist share the same working field, airway. We are sharing the same working field. And because these patients are having so many comorbidities, especially the respiratory comorbidities, they carry a very high risk for perioperative respiratory complications. So, anesthesiologist's role is pivotal in ensuring procedural safety and efficacy. This is apart from the usual challenges of non-operating room anesthesia, because these are done in the pulmonology suite, where all the challenges of non-operating room anesthesia challenges like high-risk cases. Most of these cases will be elderly and ASA 3-4 patients, and we are unfamiliar with most of the procedures. And these are done in the remote location where we may not get adequate help on time, and there is limited access to the patient and as well as the monitor. So, they do an array of procedures using flexible and rigid bronchoscopy. Some are simple like biopsies, taking brushings and foreign body removal. But there are several advanced diagnostic and therapeutic procedures are done like navigational bronchoscopy, ablation procedures using lasers, cryoablation, organ plasma coagulation, thermoplasty, even endobronchial valve placement, stent placement and balloon dilatation. So many procedures are done. So, I will initially go with the general management of flexible and rigid bronchoscopy, then I will touch the specific concern with some of these, because some of these procedures carry specific anesthetic concerns. Otherwise, in fact, the anesthetic management is almost same for the flexible and rigid. In general, the anesthetic management depends basically on the patient's clinical status, extent of the underlying pulmonary pathology and the procedural complexity. It is actually the procedural complexity that determines your technique. We all know that the flexible bronchoscopy, which allows visualization down up to the subsegmental bronchi, with the help of it, many diagnostic and therapeutic interventions can be done. And the anesthetic management depends again on the indication and the complexity of the case. So, you can basic procedures like taking a sample or a lavage, small lavage for a tissue biopsy, they can be done under minimal to moderate sedation and topical anesthesia. But advanced diagnostic and therapeutic procedures need deeper sedation or even general anesthesia. The American College of Chest Physicians guidelines recommends that all patients undergoing bronchoscopy should receive some degree of sedation to improve the patient satisfaction as well as procedural tolerability. So topical anesthesia is very safe technique. You can use lignocaine 1%. Actually, adequate topical anesthesia will minimize the gag reflex as well as coughing, and it reduces the requirement of further sedation. And in very high risk cases, in fact, you can do the procedure under topical anesthesia alone. And intravenous sedation, you have an array of sedative agents, and of which the most preferred is the propofol. You can combine with the short-acting opioids like fentanyl, remifentanil if available, or benzodiazepine. And we already had a nice session on TIVA TCI. So this is utilized for maintaining a stable anesthetic depth during the procedure. Coming to the airway management ventilation during flexible bronchoscopy, it also depends on the procedure as well as the patient. Short procedures, you require only spontaneous ventilation, and you can complete with under sedation. To improve the oxygenation, you can utilize high flow nasal oxygenation. And if the patient is already having respiratory failure with high oxygen requirement, you can utilize non-invasive ventilation during the procedure to maintain the oxygenation. And of course, when they use a flexible bronchoscopy, always use a bite block to protect the bronchoscope. And the procedures requiring deep sedation or general anesthesia, you can use either endotracheal tube or supraglottic airway device for airway management. Supraglottic airway device is preferred because of the minimal stimulation it causes, and it also offers better access to the larynx, subglottic and high tracheal lesion. When you use if you use a endotracheal tube, it can traumatize the tracheal lesion. So for a higher tracheal lesion, supraglottic airway device is preferred. But you should remember that the supraglottic airway device is prone for displacement and potential airway leak, because these pulmonologists, they frequently introduce and withdraw this bronchoscope. So this frequent change in the introduction withdrawal, there is possibility of displacement. So you have to monitor this constantly, ventilation. And if you are opting for complete GA or a deep sedation, it's safer to go for an endotracheal intubation with a larger size tube. And always utilize this swivel adapter. This swivel adapter, especially if you are using an endotracheal tube or a LMA, and through that opening you can they can put the flexible bronchoscope. And this swivel adapter will help you to allow continuous ventilation and bronchoscopy simultaneously. You can use any sedative agents. I am not going into the dose details, but remember, propofol being a drug with a narrow therapeutic window, you need vigilant monitoring, and the presence of anesthesia provider is essential, because there are many pulmonologists and many physicians, they are giving sedation by their own. So this is a drug with a narrow therapeutic agent. Dexmedetomidine is a newer agent. The one thing is, in nebulized form in these pulmonary cases, it can reduce coughing and improve the tolerance and relieve bronchospasm. A recent agent is the remimazolam. If it is available, it is an excellent agent because of its unique organ independent elimination. So it is highly safe in high risk cases. Inhalation agent during bronchoscopy is highly discouraged because there is difficulty in maintaining anesthetic depth, because they will do frequently suctioning they will be doing. And another point is this, because of the leak, it can contaminate the procedural room also. So inhalation agents is not preferred, rather TIVA TCI is the most preferred. Coming to the rigid bronchoscopy, compared to flexible, this is a very large equipment. So it can accommodate a wide array of instruments like mechanical debrider, laser probes, balloon dilators and stents. So it is used in such procedures. So since it is a large equipment, it generally requires general anesthesia with complete muscle relaxation. Here also inhalation agents are not preferred because of the inability to maintain the depth. But in a pediatric patient, for a foreign body removal, we generally use sevoflurane induction because of the rapid induction and rapid recovery. And ventilation, with rigid bronchoscopy, spontaneous ventilation is not preferred because it is very difficult to maintain. The patient will go on for coughing and breath holding. So you can go for either intermittent apneic oxygenation or assisted or controlled ventilation, or go for a jet ventilation. Intermittent apnea, that what we use sometimes in foreign body removal, that you pre-oxygenate and after inducing you ventilation is suspended and you hand it over to the pulmonologist to do the procedure. Then once the SpO2 start falling and reaching the threshold, the procedure is paused and you again ventilate to improve the oxygenation, and then you again that cycle is continued. And this is not a favored technique now because there is significant acid base disturbance occurs, and there is also possibility of awareness and hemodynamic instability. So intermittent apneic oxygenation is not a preferred technique now. So you can either go for an assisted or controlled ventilation. In a spontaneous assisted ventilation, in which propofol based TIVA is titrated to maintain the spontaneous ventilation, and your anesthesia circuit is connected to the bronchoscope, and the support, ventilatory support is provided as needed in synchrony with the pulmonologist. And controlled ventilation is less used with flexible bronchoscopy because of the airway leak and inadequate delivery of the tidal volume. In rigid bronchoscopy, what is most beneficial is the jet ventilation, which can be given by using either a manual or a mechanical jet ventilator, which is attached to the side port of the rigid bronchoscope. Either you can go for a high flow, high frequency or a low frequency jet ventilation depending upon the procedural requirement. The advantage of jet ventilation is you are giving a very small tidal volume, that is less than dead space ventilation. So the procedural field is quiet. Because if you are giving a large tidal volume like a conventional ventilation, that large tidal volume will cause disturbance in the surgical field. So this small tidal volume with jet ventilation offers a quiet procedural field, and it also maintains a lower mean and peak airway pressures and greater hemodynamic stability with jet ventilation. But there are problems also. The other things to keep in mind with jet ventilation is your driving pressure and IE ratio should be adjusted. The pressure should be maintained around 20 psig, and the inspiration should be limited to 30 to 40% of respiratory cycle. And the most important point when you use jet ventilation is that always make sure that the outflow or the expiratory gas flow is not obstructed, otherwise it can cause barotrauma. So that is a complication, most important complication with jet ventilation, that is barotrauma causing pneumothorax, pneumomediastinum or subcutaneous emphysema. Other complications with jet ventilation are hypercapnia, hypoxia, bronchospasm, and the high flow can impair the mucociliary, normal mucociliary clearance. So mucociliary damage can also occur with the high flow of the cold dry gas. So airway pressure monitoring has to be done continuously to prevent barotrauma. Usually the flexible bronchoscopy is safe and not many major complications, but rigid bronchoscopy can have complications because it is highly stimulating, can cause bronchospasm and laryngospasm, sometimes can cause trauma causing bleeding, it can initiate trauma and the barotrauma as I already discussed, and it can also cause airway perforations, and sometimes if they use electrocautery or lasers it can cause airway fires. Now we will, I will see what are the specific anesthesia concerns in some specific procedures. First, the most common is the endobronchial ultrasound. It is nothing but a large flexible bronchoscope in which there is a ultrasound transducer probe is incorporated at the tip. And with the help of this, they can do the diagnostic bronchoscopy. So endobronchial ultrasound guided transbronchial needle aspiration, EBUS TBNA. This is an advanced diagnostic bronchoscopy which is utilized to take peripheral lung lesion biopsy as well as sampling of the mediastinal and hilar lymph nodes. Actually, this mediastinal sampling has totally replaced the invasive mediastinoscopy. So this EBUS guided transbronchial needle aspiration, actually it offers simultaneous visualization and real-time direct needle aspiration. You can see with the help of the real-time ultrasound guidance, you can direct your needle. So the precise needling is the advantage of this technique. So since the probe is large and this probe needs close contact with the tracheal or bronchial mucosa to get the clear image, it can cause stimulation of coughing, bronchospasm, and this may hamper the accurate needling. And even it increases the risk injury to the mediastinal blood vessels, because most of the mediastinal lymph nodes are close to the major vessels. So this technique, EBUS TBNA, prefer deep sedation, or in fact GA is safer. Sometimes this procedure may be take long because sampling of the adequate sampling may take long time. And immobility and precise positioning also needed for some of the lesions which are close to blood vessels. So when you use an EBUS TBN and you are going for an endotracheal tube anesthesia, make sure that you put a larger size endotracheal tube. So from the picture you can see that this EBUS probe is almost 6.6 to 6.9. So you need to put a tube of more than 8 millimeter size internal diameter. Another technique is a navigational bronchoscopy, which is utilized to take biopsy from the peripheral lung lesion which are distal to the usual bronchoscopic reach. So the two techniques are electromagnetic navigation and robotic assisted navigation. Actually this navigation technique, it creates a 3D virtual map with reference to the pre-procedural CT and through which the bronchoscope probe is navigated to locate the lesion. So pre-procedural CT is taken and with reference to that it creates 3D image, virtual image is created, and with the help of that the pulmonologist navigate the probe to locate the lesion. In the anesthetic technique same as for EBUS, that is GA with controlled ventilation is required. But the important point while giving anesthesia to the navigational technique is, we know that our general anesthesia creates some amount of atelectasis because we are using high amount of FiO2 during pre-oxygenation which cause absorption atelectasis. So these atelectasis can obscure the lesion, they may reduce the diagnostic yield. And this atelectasis also increase the pleural injury risk also. And sometimes these atelectasis can mimic like a lesion also. So the overall diagnostic yield is reduced because of this atelectasis. Actually it causes the body to CT to body divergence, that is mismatch between the pre-procedural CT based virtual image map and the actual dynamic lung anatomy during bronchoscopy because of the anesthesia induced atelectasis. So some of the preventive strategies which we can adopt are including the like pre-procedural incentive spirometry, and you go for a lower FiO2 during pre-oxygenation as well as maintenance, use of PEEP during induction, and recruitment maneuvers just after intubation, and maintaining a high PEEP throughout with a low FiO2. Another procedure, advanced procedure, is the bronchial thermoplasty, which is used in advanced chronic asthma patients, in which radio frequency energy is used to reduce the airway smooth muscle mass in patients with a severe asthma. So these patients already in an advanced state of asthma. So preoperative optimization with clearing the respiratory infection and pre-medication with a dose of steroids like methylprednisolone and anticiolog is very important. Another is the airway stents. These stents are hollow cylindrical processes of various material, either silicone or metallic stents. These are placed to support and maintain the airway patency. This can be placed in the trachea or mainstem bronchus or bronchus up to bronchus intermedius. The indication for stenting include symptomatic central airway obstruction as with a benign or malignant lesion. Actually these stents protect from tumor ingrowth, and with a large mediastinal mass which cause the airway compression, in which a palliative procedure or debulking is required, then you can go for the stenting. And in tracheobronchomalacia, in which there is a dynamic airway collapse, here also you can utilize these stents. And when for the healing or management of airway fistulas, tracheobronchial fistula, here also you can use airway stents. There are two types of stents, silicone stents and self-expanding metallic stents. Silicone stents can be deployed through the rigid bronchoscope, whereas self-expanding can be deployed through FOB. The anesthetic concerns are as per the procedure. Mostly the GA is often required because you require a precise positioning of the correct placement of the stenting. So a quiet field is required here also. So go for a general anesthesia. Another commonly performed technique is a bronchoscopic ablation of the endobronchial lesions, whether it is a malignant or benign lesion. Various endobronchial lesions can be ablated with various measures like mechanical debridement, using thermal technique like lasers, electrocautery or argon plasma coagulation or cryoablation. And these are done with rigid or flexible bronchoscopy, and for this also, for the precise positioning, GA with controlled ventilation or spontaneous ventilation is required. And the important point to remember is during thermocoagulation using laser or electrocautery, reduce the FiO2 to less than 40% to prevent the risk of airway fires. With cryoablation, though there is no risk of fire risk, because of the rapid expansion of the liquid nitrogen in the airway, it can cause hypoxia and gas embolism. Also, it increases the incidence of barotrauma. So, with the cryoablation, though there is no fire risk, this risk of hypoxia and gas embolism has to be remembered. Now come to the another advanced technique is the endobronchial lung volume reduction. We have heard that in advanced emphysema and COPD, there is surgical lung volume reduction. So, this is a alternative procedure, that is endobronchial lung volume reduction. It is a new tool in the armamentarium of pulmonologists. Here they are placed a valve to causing endobronchial valve is placed. The two valves which are FDA approved include sapphire valves and the umbrella shaped spirothon valve. These valves are one-way valves which are placed in the most hyperinflated lobe. So, this valve is a one-way valve which prevent air going into that lobe, but at the same time it allows secretions to coming out, draining out. So, these valves occlude the distal bronchi as it prevents air further growing into that lobe. That non-ventilated or hypoventilated valve over time will passively collapse. So, in long-standing COPD patients, the major concern is the poor respiratory reserve. So, we have to optimize with pharmacological and other pulmonary rehabilitation measures, and during the procedure avoid high airway pressures and prevent auto PEEP. And sometimes these patients may require post-op ventilatory support. And medical pleuroscopy is another advanced technique in which pleural biopsy and chemical pleurodesis and indwelling pleural catheter insertion are done. These are done and usually done under sedation, local anesthesia, usually under the monitored anesthesia care. But we can use some regional anesthesia technique like multi-level intercostal block, paravertebral or erectospinal block. These are as a single port is used for this pleuroscopy. Usually these patients are elderly with many comorbidities, usually ASA 3-4 patients. Bronchoalveolar lavage is another advanced technique. Simple bronchoalveolar lavage to take a sample is not very important, but whole lung lavage is a highly challenging procedure. I am not going to the detail, but it is used for the pulmonary alveolar proteinosis, you all know. Actually, it is physically removing the proteinaceous material from the affected lung. The whole lung lavage is done in different sittings. Each lung is lavaged separately. The lung, the non-dependent lung is actually lavaged. In this, general anesthesia with controlled ventilation, lung isolation using WM tube is required. And the non-dominant lung, non-dependent lung is lavaged with a large volume of warm normal saline, and the whole of the proteinaceous material is removed. It is a totally different topic. It requires detailed discussion actually. So, interventional pulmonary procedures are minimally invasive options for many lung diseases, which has replaced more invasive surgical procedures. So, it carries unique anesthetic challenges. So, we need to stay up to date with the newer procedures, and an individual approach based on the procedural requirement and the patient factors is required. So, you can go from minimal sedation to the complete general anesthesia depending on the procedural requirement. And topical anesthesia you can always combine, and in advanced technique in rigid bronchoscopy you can use the ventilation like a jet ventilation technique. And it requires a tailored approach. So, some of the novel diagnostic and therapeutic interventions are newly coming up. So, you always go for a pre-procedural multidisciplinary discussion with your procedure list, because the procedural requirement, the procedure itself is something new to you. So, always have a discussion with the pulmonologist, what exactly they want, what position, what duration, everything you have to discuss with them. So, effective communication and teamwork is essential for successful management of these challenging cases. During the procedure also, you have to communicate with the procedure effectively. Thank you. These are some of my references.
As usual, it was a great academic feast, ma'am, and you have covered everything in a nutshell and very crystal clear.
Actually, I couldn't cover completely. I didn't cover the anesthesia for massive hemoptysis, anesthesia for mediastinal mass, So many procedures are missing. So because of the positive iodine, actually sometimes massive hemoptysis management sometimes come up. You require a lung isolation to rigid bronchoscope to isolate and protect the other lung. And mediastinoscopies are yet another mediastinal mass, yet another challenging case.
Thank you so much, ma'am, for that excellent talk.
Thank you.
Recently, we had the recent exposure that we had with pulmonary procedures was the recent unfortunate Churalamala disaster. We had many patients who had come with aspiration, and many ended up in ARDS. They needed bronchoalveolar lavage on a daily basis. And we used to remove a lot of mud and other organic materials. And such patients, because of the lavaging, they actually improved. Many of them, we were able to extubate the patient and discharge the patient. Yes. So in such conditions, it was so challenging because the airway is shared and the patient is in a very bad critical conditions. They will desaturate very fast. And one technique that we used was we applied O2 with a connector. Instead of the suction port, we started delivering O2 through the suction port. But now, after your lecture, I think the swivel valve we'll have to get for our institution. Also, jet ventilator, we have a jet ventilator provision, I think. So we will definitely make use of it. And ma'am, are there any modalities for patients with tracheostomy? For example, we see a lot of patients who are in palliative care who need bronchoscopy with the tracheostomy tube. So
you can connect the same swivel connector there also to do the flexible bronchoscopy. Yeah, the another procedure which I missed is the for tracheostomy stenosis. Sometimes they place the T tube stenting. That also I heard about your this COVID management, not COVID, during the disaster management. I heard about it. You had done a wonderful job at that time, lavaging and taking out all the mud and other foreign materials from the. Then you have saved a lot of people.
Thank you for the excellent talk, ma'am.
Thank you, ma'am. Thank you, sir. Now, may I request Dr. Abhishek to kindly come to the stage to felicitate Dr. Suvarna K. Now, I request Dr. Sunil Rajan to kindly come to the stage to felicitate Dr. Abhishek and Dr. Devika.